So I often talk to patients, if I'm talking about orthotics, I'll talk about dosage and tolerance. Like I was traditionally taught in that root theory where you'd go, okay, you're going to get a big biomechanical assessment form, you're going to create all these numbers, and then you're going to pull out an orthotic script out of it. And I remember seeing all these students and podiatrists that would have biomechanical assessment forms that have all got different numbers on them, but the resulting orthotic was nearly always a 4 mil poly with a 4 degree rear for post. And the only thing that would change might be the thickness of the shell or the cover. And so that, to me, that wasn't real smart biomechanics. So the way I approach it is that I'll work out what tissue it is obviously aggravated, try and work out what factors are leading to that aggravation. And most of those factors are not associated with the orthotic. But of some of those factors, you can't do anything about. It might be their activity, and you can get the patient to do things about them. But when I'm focusing on the foot part, I'm thinking, okay, what prescription can I add into this neutral shell? And then I'll add my prescription to it. And so I might be adding medial wedging, lateral forefoot wedging, higher arch, lower arch, plantar fascial accommodations, met domes, whatever I'm doing to them. I can add that to the shell there and then I can shape the orthotic perfectly so it fits perfectly into the shoe. I can make the cover match perfectly, all done on the console. And then what I say to the patient is like, I've now created an orthotic for you that I think has a therapeutic dose for your condition. Okay, so the orthotic is designed for the condition as opposed to whether you have a 5 degree rift of varus or a 2 degree rift of varus. That doesn't bother me at all. I've designed it for the tissue. And now I want to see how you tolerate it. And so I then get the patient to put it on and I'll assess their tolerance. And instead of saying, one of my pet hates with orthotics is when I hear patients come in and say, I went back to the podiatrist and told them these orthotics were too uncomfortable. And they told me, no, they are right for you because I scanned or I did whatever, and they are right for you. You just got to get used to them. And to me, that's a failure in podiatry because I think an uncomfortable orthotic never works. So
Yeah.
the way I explain to the patient is that, okay, I've made a dose that I think is therapeutic for you. Now I want to assess how you respond to that dose in much the same way as you would if you went to a GP or a specialist and they gave you a medication. They're going to give you a therapeutic dose for your condition. But if you get side effects from it, they're going to back that dose off. And
Mm.
that's what I think we should do with the orthotic.